It's my pleasure today to introduce Dr. Minal, Dr. Amber Gum, and Dr. Lucy Guerra. They're going to be talking about refugee health. I think these are some of our best and brightest people in the university, and they're going to explain in depth the many issues of refugee health. And I will tell you that unless you're American Indian, you are descended from refugees. When we hear refugee, we sometimes think it's a derogative term, but it's not an insult. I think to most of us, it's a badge of strength and courage. If you reflect on what people put at risk, you realize that no one would put their child in a boat unless they think that the sea is safer than the land, which is a pretty dramatic statement. When refugees arrive, they enrich our culture, enhance our humanity, and help us create an alternate future we could never imagine without them. Our job as healthcare workers is to protect these candles of the future so they can grow brightly in the fullness of time. Please get started.
So thank you everyone for being here with us today. This is a topic that's very near to my heart because I am the child of refugees. My parents were Cuban refugees who left at the time of the Cuban Revolution, and they were given asylum through a program that the American Red Cross and the US had at the time. And they were sent to Spain and were there for several years. So my sister and I are the product of refugees. So next slide. So the objectives of this talk are for you to develop an understanding of the refugee population in the Tampa area, to develop an understanding of trauma and how it is manifested in the refugee population, to review some of the legislation that has affected refugees during the Trump and Biden administrations and throughout the course of our history, and to describe some of the approaches to certain clinical cases from refugees that we've seen through the USF Tampa Bay Street Medicine Refugee Clinic. Next slide. Dr. Ahson is going to take over here.
Hi, everyone. My name is Minal. I am an internal medicine and pediatrics hospitalist, and I will be talking, giving you a little bit of an introduction about refugees worldwide and locally. So when we hear the word refugee, that term, I think sometimes it's used interchangeably with asylum seeker and migrant. So I think it's important to have a clear idea of what we're talking about. Refugees are people who have fled war, violence, conflict, or persecution, having crossed an international border to find safety in another country. They often have had to flee with little more than clothes on their back, leaving behind homes, possessions, jobs, loved ones. Refugees are defined and protected in international law. The 1951 Refugee Convention is a key legal document and defines refugee as someone who is unable or unwilling to return to their country of origin owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion. The U.S. also has its own definition of refugee, which is defined at the U.S. Refugee Act of 1980. A refugee is defined as a person who is outside his or her country, is unwilling or unable to return to his or her own country, and is able to demonstrate persecution or a well-founded fear of persecution based on race, religion, nationality, political opinion, or membership in a particular social group. Asylum seeker is a little bit different. This is also somebody who has left their country seeking protection from persecution and serious human rights violations, but they have not yet legally been recognized as a refugee, and they're thus waiting to receive a decision in their asylum claim. So the U.S. Refugee Act of 1980 defines an asylee as a person who is physically present in the U.S. or a port of entry and is able to meet the definitions of refugee as defined above. So immigration is the act of leaving one's country and moving to another country of which they are not natives or citizens to settle or reside there, especially as permanent residents or naturalized citizens. or to take up employment as a migrant worker or temporarily as a foreign worker. So there is some overlap between the term refugee and immigrant. Both groups have left behind friends and family. They may be coping with different culture, weather, language. They may have a desire to pursue careers or goals in another country. They may require extra language and academic support. But obviously there are some key differences. Basically the differences come down to choice and planning or not. An immigrant may make this decision, by choice, so they can plan. There's not this sense of loss, and trauma is usually not present because they have the time to prepare for this transition. They can leave in summer breaks when kids are on vacation. They can return home if they would like to. It's a personal choice for them, and usually arrangements are made in advance. Refugees, on the other hand, often have to leave haphazardly. There may be a sudden transition to a new country, which creates difficulties and confusion, and returning home is usually not an option. And this may affect children. Children's school years may be disrupted, and there may not be arrangements for basic requirements of food, housing, medical care. So when I started working with refugee populations a few years ago at the end of my residency, I read this interesting fact, which I think every year continues to be true, that at this point in history, there are more refugees than at any other point in history. And this continues to be true because the refugee crisis continues to grow. As you can see, these numbers are from UNHCR, the High Commission on Refugees. There are about 84 million people forcibly displaced worldwide. 48 million people are internally displaced, so within their own country, maybe civil war, famine. 26 million people are refugees, meaning that they have actually crossed borders, and about 4.4 million people are asylum seekers. And these numbers usually come out at the end of each year. So this is from the end of 2021. 68% of refugees come from just 5 countries. So the highest number being from Syria. As we know, that conflict, that civil war has been going on for over 10 years now. Second highest from Venezuela, 4.1 million people. Third is Afghanistan, which this number is obviously from November of last year. So this number may be different this year when we look at statistics. Then South Sudan, and then Myanmar, the Rohingya refugees. And 39% of all of these refugees are hosted in just 5 countries, usually neighboring countries. So Turkey, Colombia, Uganda, Pakistan, and Germany. Some other interesting statistics is 35 million of these are children. So about 42% of these 82.4 million forcibly displaced people are under the age of 18. 1 million children were born as refugees between 2018 and 2020. There was an average of about 300,000 people born into life as a refugee. So either in a camp or maybe in an unknown city or an unknown location. About close to 150,000 refugees were returned or resettled. About 85% of refugees are hosted in developing countries. So if you think about this, a lot of the countries surrounding, as I showed in the previous slide, surrounding areas who have had the highest amount of refugees fleeing crisis, war, famine, they're hosted in neighboring countries. So 85% are in developing countries. 4.3 million people are stateless, so they don't have a country. And then, as I'd mentioned, 73% are hosted in neighboring countries. So we don't have any clear statistics yet on the Afghan refugee crisis, but this slide is from the BBC with coordination with a UN agency. And as you can see, the number of refugee crises, refugees fleeing by month, have increased since 2018. It's been increasing in 2021, as you can see, close to the end of the year, has significantly increased. We don't have really numbers yet from this year, but I will be very curious to see what that looks like in the next few months. So worldwide, what does this look like? So as you can see, this chart compares, and these numbers are from the UNHCR and the UN mission to the UN. This chart compares 2013 data to 2020 data. So 2020, as you can see, the highest number of refugees are from Syria, 6.8 million, the next from Palestine, next from Venezuela, then South Sudan, then Afghanistan at 2.8 million. And like I said, this is 2020 data, so we don't have the newest data about that includes the end of 2021 and currently in 2022. In the Ukraine, this is a comparison chart from February 24th to March 2nd, which was the most updated data. It was about 1 million. By the end of the crisis, it's estimated to be at about 5 million. Right now, the refugee crisis is noted. I think the most recent estimates are about 3 to 3.5 million people who have fled the conflict in Ukraine. So that puts it at like the fourth highest number of refugees currently from one country. So how does this impact us locally? So this data is actually from the Department of Children and Families Refugee Services Program. It's federally funded by the Office of Refugee Resettlement within the Department of Health and Human Services to assist refugees to achieve economic self-sufficiency and social adjustment within the shortest possible time after arrival to the US. So while in recent years, the number of arrivals has decreased nationwide, the state of Florida's refugee program, per their website, is actually the largest in the nation. So these statistics that you see here are actually from the fiscal year. So they actually count their fiscal year from October 1st to September 30th. So this is from October 1st, 2020 to September 30th, 2021. So these may not have some of the most updated data. But to give you an example of what we're talking about, so we discussed who an asylee is. An entrant is actually a person from either Cuba or Haiti who has been granted special immigration status by the US. Most often it's called humanitarian parole that makes them eligible for refugee benefits and services. Refugee we discussed. An SIV is someone here on a special immigrant visa. A VOT is a victim of severe form of trafficking. And then so this may be somebody that's a US non-resident who through use of force, fraud, or coercion has been kind of involved in commercial sex acts or recruited, harbored, or transported to provide labor or services in the purpose of involuntary servitude, debt bondage, or slavery. So, and then this world parolee, usually we see it in the context of the prison system, but a parolee in the immigration system is an available tool under the Immigration and Nationality Act, so the INA, that allows certain individuals to enter the US and temporarily stay without an immigrant or non-immigrant visa. So as you can see, from October of 2020 to September of 2021, about 30,000 people entered the United States, or sorry, this is Florida. Sorry, 30,000 people are just arrived in Florida. And this is the breakdown by county. So I'm gonna bring it close to home and our, Tampa Bay area, what kind of numbers are we seeing? So as you can see, predominantly we're seeing entrants from Cuban and Haitian origin. We are seeing some refugees as well. We have a few asylees and a few Afghan parolees as well. And then which countries do these, newly arrived residents come from? So as you can see, this is our local Tampa Bay area. We have some from Afghanistan. We have a few from Chile, many from Cuba and Haiti, some from Mexico, Venezuela, and other. And as you can see in Hillsborough County, in the 2021 fiscal year, this was about 3,000 newly arrived residents. This is the most updated recent data from the Department of Children and Families. They just emailed this to me this week that shows they don't have proper numbers just yet of how many people have been resettled. I think it's kind of between the National Office of Refugee Resettlement and local organizations, there's sometimes a lot of flux and it's difficult to get updated data right away. So hopefully within a month or two, they will have that. But what they were able to provide me was Afghan clients that have completed health assessments. So that is one service that is afforded to newly arrived refugees, that there is a health assessment from the Department of Health from each county, with that if each refugee is able to come and complete, to complete their health assessments. So this is actually a list of a few counties that they were able to provide me data from. 06, starting from the top, is Broward, 13 is Miami-Dade, 16 is Duval, 17 is Escambia County, 37 is Leon County, 52, and why I put the arrow there is the only one they could provide me from Tampa Bay area, was Pinellas County, and then 58 is Sarasota County. So as you can see, not all of these have every month from January till now, but around 500 newly arrived residents completed the health assessment. So, the estimation is there are likely more who have not yet completed the health assessment that are living that are newly arrived. So I think the data for this fiscal year will show that and will be available at the end of September. And now turning over to Dr. Gum.
All right, thank you. Hi, everyone. Amber Gum, psychologist. And so I think you can go forward. So we can think about trauma with refugees in multiple phases. So there is obviously some kind of trauma and threats, in their pre-migration phase, in their home area. And some surveys and systematic reviews show that very common types of trauma that people experience in their home before they leave do include things like physical violence, being tortured. Sexual violence is unfortunately fairly common for females and for males, being deprived of basic needs, and then witnessing others who are being tortured or traumatized. So trauma is common before people leave, and then of course trauma can occur during someone's travels. So including being deprived of basic needs, as well as other kinds of danger and violence that can happen while someone is traveling. Once someone has arrived, things aren't necessarily, it's not necessarily smooth sailing. So kind of in that post-migration period, when someone has arrived, it's, they're dealing with the trauma that they've already gone through, and they're in a new culture, in a new place, may not have access to all of their basic needs, and a way of providing for themselves and their families. So, and some common issues that happen here, this changes in family dynamics. So some of the issues that we've seen in the clinic have to do with intimate partner violence and arguments that can occur, as well as tension across generations. So, maybe between children who are getting into the school system, and in here locally, what we've observed, children getting into the school system, getting more acculturated into American culture, and which can lead to some tension with parents. So and then there's some other kinds of post-migration issues as well, political issues, technology, which is actually very common with modern refugees. So one article referred to them as techfugees, kind of merging these words, that a lot of people, they used their devices all throughout their transition, throughout their leaving, sometimes to plan, as well as in their travels, and the importance of technology for staying in touch, for staying in touch with their loved ones, and keeping track of how others are doing who also might have left home and gone in different directions. We do have some systematic reviews now that show a wide range of mental health issues, both, in terms of our kind of Western conceptualization of mental health issues, PTSD, depression, anxiety, psychosis, while not common, is more common with refugees than it is in the general population. And then somatization, and this is an important one to keep in mind, that not necessarily that the person is making up their physical symptoms, but that, stress and trauma do impact our physical bodies and can absolutely contribute to or exacerbate physical health issues. So you always need to think about that, physical mental interplay with their physical symptoms. And this is a model of responding in a kind of multiphasic way. So responding to the trauma. And it's important with mental health education to be flexible and not overly prescriptive with kind of our Western conceptualization of mental health and how symptoms are displayed. So, but it can be it can be helpful to talk to someone about how that they've validating that you've been through a lot, and it can be expressed in a variety of ways, so that the symptoms, the things that you're experiencing are understandable, and so just that validation piece. And then there are other pieces, there are other aspects of responding to trauma. So we can use psychotherapy. Of course, we need to be very culturally sensitive, aware of differences across cultures of how people express distress, and culturally responsive, in how we're interacting with them. So again, as opposed to prescribing cognitive behavioral therapy, which is my predominant way of working, but making sure to be flexible here. Cultural empowerment is so how, and indigenous healing. So with these aspects, what works in your culture? What strengths do you bring from your cultural background in healing, and how can those be incorporated here? So, and then the last piece here, human rights. So part of this being advocacy for, trying to help refugees, both the individuals and families that we're serving, as well as on a larger scale, trying to improve the processes. One of the things that we see are challenges around refugees who have been separated from families and trying to bring other family members here, and sometimes being separated for a very long time, and just the difficulties and how many barriers that they come across in the amount of time that can go by with very limited, if any, progress on those kinds of issues. So I want to mention just briefly that we try to take a trauma-informed approach with Refugee Clinic, and you may have come across these concepts before, but this is from SAMHSA, and these are the core principles in general to a trauma-informed approach, which has been applied in healthcare settings as well as in other kinds of social service, behavioral health, and educational settings. So, trying to foster a sense of safety, being as transparent as possible, trying to encourage peer support as much as possible. And I know some of the community organizations that the Refugee Clinic works with does a lot to try to connect peers together. Collaboration, so collaborating with patients and families that you're working with, trying to minimize power differentials, empowerment, and then humility and responsiveness. And I believe the next slide shows that this is a model of trauma-informed care that's been applied to healthcare. This is by Dr. Edward Mongering and colleagues at the University of California, San Francisco. So at the foundation, is that your clinic is operating from a trauma-informed care framework, and that everyone in the clinic setting is aware of the basic values and practices of trauma-informed care, that when you're interacting with patients, that you're providing some basic education about trauma and how trauma can impact physical and behavioral health in a variety of ways. And also sending that message of hope for, hope and expectation for healing and for improvement for patients. You can inquire about trauma in a variety of ways. We tend to assume trauma with refugees. They're invited to tell their story, particularly in their first visits, and so the providers get a little bit of their story, but it's up to them the level of detail and what they tell about their stories, and then we assume that there's more, that there's more than they have told us of what they've been through. And then the response, so of course, empathy and compassion, on site trying to provide as many services and assistance as possible, and then those community connections as part of that response. And I think it's to Dr. Guerra now.
So now I'm going to be talking a little bit about legislation and how that has impacted refugee health. Next slide. So here are some of the legislation that has been passed throughout the course of our country's history with regard to refugees and immigration. There are many, many bills and legislation, but I thought I would highlight a few. So I'm not going to go through each of them, but I'm going to go through at least the ones that I think have impacted us the most when it comes to the Afghan refugees and what we're seeing now. So just as a little history, in 1891 is when the Bureau of Immigration was established, and that encompassed immigration as being primarily refugees. We didn't really refer to people as immigrants at that point, at least when it came to legal matters. And then we have the Immigration Act of 1917, probably the most impactful, particularly to those fleeing from countries that were that had descendants that were Jewish, were impacted by these quota acts. Then we had World War II that led to a huge influx of refugees. And then finally, in the 1950s, we started to have some conventions relating to the status of refugees and how they should be treated. And you'll see in a moment how literacy actually played a role. And then finally, the Department of Homeland Security that was established most recently in 2002, 2003. Next slide. So if you look at the history of refugee and immigrant legislation in our country, there's a persistent theme of fear mongering, at least if you read some of the academic literature and the way that this has been described, which is, the refugee, the immigrant is the enemy. We have seen that throughout our history. We continue to see that probably even more so today with the most recent administrations. And as a result, there's been a lot of legislation throughout the course of our history that has kind of focused on that. So in 1891, I mentioned that the Bureau of Immigration was established. The whole idea was to consider people that were coming to the country refugees, but early immigration laws did not restrict the numbers that the U.S. would accept. There really were no separate laws for how many we were going to admit and how many could resettle. So it was pretty vague at the time. And then we had other legislation that was passed. In 1917, the Immigration Act was passed. And this required all immigrants that were age 16 and older to demonstrate that they could read. And the thought behind this was that if you could limit, or this would be an effective way of limiting the number that would come. And it wasn't really quite effective, though. But they did make exceptions, though, for religious persecution. Next slide. So then the Emergency Quota Acts were passed. And what I find particularly interesting about this political cartoon, is that you could use the same cartoon to apply to what's happening today. You know, you have bazillions, so to speak, of refugees in Europe now, particularly with Ukraine trying to leave. You could probably apply the same cartoon to South America, Central America. But these particular acts were known as the Quota Acts, and they set specific limits on the number of immigrants that the U.S. would admit and how many they were going to call refugees. It seems like if you look through some of the academic literature, they had a hard time figuring out who they were going to call a refugee, who they were going to call an asylum seeker. It's kind of confusing, and that has been further delineated over time. The strict quotas later contributed to the many, many difficulties that Jewish people and other minorities faced as they tried to come to the U.S. After World War II, and then in particular the Holocaust. And then I should mention that, you know, some of this legislation has been kind of reflected in some of the comments that have been made by the Trump administration and others, not to just focus on Trump, but that, you know, refugees pose a danger. You know, they're the ones that go on Medicaid, that they're the ones that suck up some of our resources, which really the data does not bear that out at all. And it's interesting, though, that here we are in 2022, and we're seeing some of the same things that happened over 100 years ago, or close to 100 years ago. Next slide. So in 2002, 2003, the Department of Homeland Security was established, as well as all of these various agencies. Some of them existed previously, but the establishment of the Department of Homeland Security almost gave them like more accountability for how they were going to count folks with regard to whatever label they were given as refugee or asylum seekers. What I think is probably the take-home message from these various pieces of legislation is that, you know, it is really up to the particular administration to set their number of refugees they're going to accept. That really is up to the president and his administration. When we got to the Trump years, I believe we had a total number of maybe like 20,000 people accepted a year. And if you went back to the Reagan administration, it was near 100,000. So it's just very interesting, you know, how that really is left to particular administration, and that they can determine what their quota is going to be per year. I should also mention that there are some things referred to as the lottery system when it comes to refugees. So the one that you guys may have heard of is the one that exists in Cuba. I actually have several family members that won the Cuban lottery. And the way that worked was that during the Castro administration, Fidel Castro, you know, he didn't want people that disagreed with his government in the country. So he set up a lottery system where you could apply for this lottery. And some people think it's rigged, so that if you had family members that had been imprisoned because they disagreed with the Castro administration, once they got out of prison, then their families won the lottery. And so I have a member of my family who was imprisoned for 20 years because he disagreed with the Castro government, and he was part of, you know, different things that were done to try to dissuade communism. And when he got out of prison after 20 years, he and his family won the lottery and were able to come to the United States within 6 months of him being released. So those lotteries still continue. How they're run and how they are applied depend on the particular administration, and it's just kind of very interesting, you know, if you go back and kind of look at the history of those lottery systems. Next slide. So what is the connection between legislation and refugee health? So a lot of the refugees that come, you know, to the U.S., including in the past and now, they do have access to health care, at least initially. The problem is that there's not a lot of legislation that exists that determines what's going to happen to them after they've been here for 6 months or been here for 12 months. So a lot of them may get some sort of health care. You know, we do a lot of these exams that are done through the Department of Refugee Services, health exams to make sure that they're not carrying infectious diseases. They get a physical exam, they get vaccines, but then there reaches a point where that kind of disappears, and they may have access to Medicaid for a limited period of time, but then there's nothing else. It's like no thought has been put into what happens to these people once they've been here for a year or longer and are trying to resettle and find jobs and maybe learn the language. And then as a result, you could argue that they are a burden to the system. However, the system has not empowered them when it comes to their health care to make it easy. And as a result, that's why we have things like the refugee clinic through Tampa Bay Street Medicine. Next slide. So now I'm going to go over with you a few clinical cases that we have seen through Tampa Bay Street Medicine, but I'm going to give you a little bit of an overview of what we do. Next slide. So the mission of Tampa Bay Street Medicine is that it's a student-run organization at the University of South Florida, which is committed to providing compassionate medical care to refugees, the homeless, and the underserved in the Tampa Bay community. And under the Tampa Bay Street Medicine student-run group, we have a variety of different types of clinics, one of which is the Refugee Clinic. Next slide. So homelessness is a group that we have clinical services for. We try to address mental health issues, substance abuse issues, trauma, unemployment. And so we see a lot of those same themes that kind of then are reflected in our refugee population. Next slide. So these are the various types of delivery services that we have. We have a continuity clinic that is primarily for homeless patients. We're now partnering with Tampa Hope. We partner with Pioneer Medical Group that is through Advent Health to provide mobile services. We have street runs for homeless patients. We now have a syringe exchange program. We just started a women's clinic, and these are all primarily for homeless patients. But then we have the refugee clinic, which is a specific clinic that is geared towards those that are refugees seeking asylum, etc. Next slide. So the refugee clinic has free lab services. We offer mental health counseling primarily through Dr. Gump's help and some of her colleagues. You can see here the various community organizations that we partner with. They refer patients to us, and Janet Blair is one of our community partners who helps to run or is in charge of the refugee services here in the Tampa Bay area. And we've worked very closely with her and her team so that we could get patients appropriately referred. And these are the number of patients that we have seen, a total number of 32, which is ever growing. But you have to understand that a lot of these patients come back fairly often. So for a clinic that basically got started at the beginning of the pandemic, we really have succeeded, I think, in getting referrals, trying to increase the number of patients we see, and providing continuity of care for all of these that are being referred from these different countries. It's not a simple visit for a refugee. They come, we have to figure out how we're going to use our translation services or a translator in person, what sorts of things we're going to be able to offer them, which does not just simply include medications, but sort of support services. And we've even had some programs to provide them with, free groceries and that type of thing. And we have succeeded throughout the pandemic, primarily because of our students. If it wasn't for them, this would not exist. And it was all kind of their appreciation of the fact that this was needed, and it was started by them with faculty support. Next slide. So I'm going to talk to you a little bit about some of the patients that we see, and I'm going to start with the Darien Gap, and this is why I'm starting with this particular slide. So the Darien Gap is the only spot where the Pan American Highway runs from Alaska all the way to the tip of South America that just dissolves into mud. And it is essentially a gateway for refugees to come from Central and South America, and even from Africa and other countries in Europe. Because they make it to these Central or South American countries to get to the U.S. It is 60 miles between this area of Panama and Colombia. There used to be very few crossings some years ago, but now, as you can see by this statistic, according to the International Organization for Immigration, 100,000 migrants walked across in 2021. This was 3 times as much as in 2019 and 2020. And basically, this area is like a jungle. People take their lives into their hands when they get across this gap. There's guerrilla fighting. There are drug cartels. People cross with babies, and they have very little support from either government. Really, very little has been done. And it is just amazing that this is what we see in our clinics. And interestingly enough, on public radio and PBS, they had a whole section that was done in one of their news programs about the Darien Gap, and they sent a reporter there to just document, how bad this is for people who are trying to cross and how desperate it is. So it's just something that we see with some of the immigrants because they have crossed the Darien Gap to get to us. Next slide. So this is one patient in particular. So this gentleman, we're just going to call him Luis from now. He was from Cuba. And, you know, Cuba has had a relationship with Venezuela and their government for a number of decades now. And so they were sending people like Luis to Venezuela to supposedly help during the during 2020, early on in the COVID pandemic. He wasn't a physician. He was like a healthcare tech. And so that's why Cuba sent him to supposedly help their amigos, so to speak, if you look at the way that they phrase literature in Venezuela. So when he was there, he made some ties, because he spoke English, with people that were able to get him a cell phone that he could call his sister. And so he would go to parts of Venezuela where there was cell phone communication. And as he tells his story, he was able to call his sister in Miami. And interestingly enough, his sister came as a refugee, but now works for TSA and has been here a number of years. And somehow he was found out that he was having these unauthorized communications, and he was sent back to Cuba as a traitor, and he was charged and put in prison. And you know, there's a lot of bribery that goes on in Cuba. So to make a long story short, he was able to bribe an officer, and eventually, with falsified credentials, made his way to Colombia and crossed the Darien Gap. It took him 14 days to cross the Darien Gap. He was by himself, although he had some others that crossed with him that became his friends that were from Haiti and other parts of Africa. He had dysentery. He said he lost like 20 something pounds just in those 14 days. He was just in horrific shape when he was able to finally get across. And he describes it as just hell. He saw babies that were dead in the mud. You can see pictures if you look online and at some of the reports from PBS, people just leaving things behind because it was too heavy for them to carry. So it's become like a wasteland of people just leaving clothing and backpacks, etc., which then also poses a harm to the environment. But that's what people are doing with 100,000 people crossing this particular area. It's really become a health hazard, not only for the people crossing, but those who live around the area. And eventually he did make it to the United States, and we saw him in our clinic. He had diabetes, he had high blood pressure, he was suffering from panic attacks, and when he was in Cuban prison, he underwent torture. And so this is the type of torture that he described, and that's why I put this picture in there that I found from the internet. And he was held like that for, you know, multiple hours, and has developed neuropathy of both of his upper extremities. Next slide. So the common problems of common health problems we see in refugees are a lot of the same things we just talked about already. Poorly controlled chronic conditions. A lot of these people haven't had access to healthcare for years and years. You see someone who's 40 years old, they look like they're 80 years old when it comes to their health conditions. They have a lot of mental health issues. Some of them have experienced tremendous torture, have lost family members. We have one lady from Rwanda who had, I think it was 8 members of her family that were killed. A lot of them require some level of maternity care. Maybe they had some complications when they were pregnant, when they came over as a pregnant patient. We've seen a few of those. And then there are a lot that have just suffered from, you know, communicable diseases that have not been treated, like TB, STIs, parasitic infections, etc. And many of them have not received vaccinations. Next slide. So now I'm going to let Dr. Ahson and Dr. Gum talk about this next case.
So this was a patient that we saw pretty recently, male in his 40s from the Congo, and we had a couple of different ways of communicating with him. For some conversations, there was an in-person translator, someone from a local community organization who speaks Swahili, which I believe is his second language, not his primary and preferred language. But so had an in-person translator, and then used a phone service for other parts of conversations. So we don't know a lot about his story of why they left and how they left, but we know that he and his family arrived in the U.S. in 2021. So they arrived last year with his wife and several children. And So toward the latter part of 2021, he had a psychiatric hospitalization. So the police were called and he was taken, and he actually agreed to be hospitalized. So, and he was hospitalized for 2 weeks. When I spoke to him, it was his second visit to the refugee clinic. Dr. Guerra and the medical students had seen him the month before, and he had brought his papers with him. So he had brought his papers from the, I believe from Grace Point. The diagnosis on the papers, on the discharge papers, was adjustment disorder. He was there for 2 weeks and was taking several medications, including an antipsychotic. So that's a long time to be hospitalized and a lot of medication for a diagnosis of adjustment disorder, but that's what the documents showed. And one of the things that can be challenging and I think is interesting about this work is just communicating and trying to get someone's story. And his story varied. The version that I got when I spent a very long time talking to him at his second visit varied from what he had, from what was recorded and what he had told Dr. Guerra and the medical students. So he did in both visits, he did acknowledge verbal arguments with his wife. And he says that they didn't have any problems before they got to the US. So, that these problems started after they arrived. And the first time in the first visit, he acknowledged that they were arguing and the police were called, and then he was taken away. When I spoke to him a month later, he was very insistent that everything was quiet, they weren't arguing, and the police just showed up. And although during our conversation, he did acknowledge some arguments, and I did inform him that in the United States, if neighbors hear arguing, if they're concerned about arguing and fighting, neighbors will call the police, and the police will sometimes show up. I did want him to be informed and aware that that is something that commonly happens here. And he did comment, and this is, through the translator, he did comment that a couple should be allowed to argue without the police being called. So I'm not quite sure, exactly still. And, one of the things that I have learned is needing to ask your question a half a dozen different ways and circling back around, I'm kind of confused. You said this earlier, and then now you're saying this, or, it sounds like you had told this to someone else. I'm just confused. I want to make sure I'm understanding the story of what happened. So at some point I let it be because we've been talking a very long time. And, so at some point I think you work with what the person's giving you, and you work with what they're ready to work with. But when he came back after the 2 weeks of hospitalization, his wife had gotten a restraining order. And this was now a few months after, and he had not seen his wife and had not seen the children. He was living with a roommate. What he would acknowledge too was being sad, that he was sad and he was worried about his family, and he was sad that he missed them. One of the things he did say is, what if I become ill, who would take care of me? So I think he's also worried about himself being isolated and not really having much support. He did have some community contacts, and what we focused on was, you've got these legal issues going on. Those are complicated. Those are going to take some time. I will reach out to with our community collaborators to see what, if anything, could be done about allowing you to see your family. I've not made progress on that. But in the meantime, let's talk about what you can do, what can help you to cope with being separated from your family. And so, so we talked about, we did talk about just daily activities and daily kind of coping strategies. that he could use just to manage that sadness. So, and then, you know, given that he'd been on medications, he had thought that it had been helpful. And so that's when, you know, I went to talk to Dr. Ahson about should we, you know, should he be on any medication, which of course is her area, not mine.
Sure. So at this point, you know, after hearing kind of, and Dr. Gump spent so much time with him. This visit took an hour and a half, 2 hours, I think. It was a very, very long visit. And I was seeing other patients. So I got the summary from Dr. Gum and we chatted with him for a little bit of time. But it seemed like he had been off of the medications for a few weeks at this point. So my thought was, you know, at this point, whatever was helping him had washed out, and he seemed relatively, his symptoms seemed to be better. At this point, he seemed to be not as in the angry, aggressive place he was when whatever incident happened. And obviously his take on the situation had varied over time and how he viewed it at this point. So so in consultation, we just decided to start him on fluoxetine based on basically, you know, with patients that don't necessarily have proper health insurance or prescription coverage. I think we used, you know, Publix or Walmart's $4 plan to choose a medication that we thought would be affordable to him. So we started low-dose fluoxetine, and we asked him to come back at the next clinic visit so we could see how his symptoms were going. We didn't decide to go with all of the medications that had been prescribed at Grace Point because he seemed to be in a better place. And if the diagnosis of adjustment disorder was correct, then maybe perhaps he was starting to kind of get beyond that. So, so that's how we made that decision. I wanted to also emphasize the importance of interdisciplinary care for these patients. I felt like it was so wonderful to have Dr. Gum there to spend a lot of time and get a lot of the history that, you know, we may not be able to get in a 15-20-minute visit when you're focusing on more of the physical complaints, you know, to have that counseling and therapy, which is so essential for populations that are coming out from trauma. As this patient had mentioned, you know, they didn't have issues prior to you know, relocation, prior to immigration. And then, you know, with the stresses of, you know, being in a new country and a new culture and language and all of these things can be so stressful, not, you know, excluding the trauma that these populations have experienced prior to coming. And, you know, my experience has been with a lot of refugee populations overseas, and this is one area I feel that is often lacking and can't really be provided in, you know, refugee camp settings or, you know, where there's minimal follow-up or internet. So I'm so glad that our clinic has the opportunity to provide patients with these kind of services because they're so needed. And I wanted to discuss one more case that we saw in the emergency room that I personally saw this patient, and then I referred to our clinic because she didn't have any kind of clinic follow-up or any insurance coverage at this point. So this was a female in her 60s who had recently arrived from Afghanistan. I just saw this patient in clinic last month, so in March or in March, sorry. I'm trying to keep it straight. So she had just recently arrived. You can imagine with the political situation and the immigration crisis, the refugee crisis that was happening. She had just newly arrived a few weeks before. I saw her when the Tampa General Hospital ER was really packed and she was on a stretcher in the hallway with a family member sitting at the bedside. You know, we tried to call from Siricom to get a translator that spoke the dialect of Farsi that she spoke, but it didn't really work. There wasn't too much understanding, so we ended up using a family member on the phone to translate. So she had newly arrived in Tampa recently. So she presented her chief complaint in the ER was shortness of breath and chest tightness. And then upon further questioning between her and this family member on the phone, she was unable to obtain refills of her medications. So she, pulled out these bottles and pulled out inhalers that she was previously on. And it turned out that she was on a long-acting steroid, beta agonist combo inhaler, as well as she had an albuterol inhaler with her. So she was telling me that because of difficulty in getting the medications, she was kind of spacing out how she was using them, which is not uncommon in patients who cannot afford their medications. We hear this probably in our clinics a lot. So she was spacing out how she was using her daily maintenance inhaler, as well as her rescue inhaler. So, when I examined her in the emergency room, she was clearly wheezing. She was not hypoxic, but she appeared tachypnic. So we started her on steroids, nebulizer treatments, and, overnight she improved a lot. But in talking to her more in a review of systems, she also was describing insomnia, generalized myalgias, and body aches. So in discussing it with it further, from my previous experience in refugee camps, a lot of times these psychosomatic complaints stem from psychological or psychiatric kind of concerns. So she did meet the criteria for either MDD or adjustment disorder. So I actually started her on mirtazapine. We provided her education on how to use her asthma medications. And then she was discharged. We followed up with her in clinic a few weeks later. She had been taking the mirtazapine and said she actually felt so much better taking the medication. She was sleeping better, her anxieties, her mood had improved, but she was also spacing this out. So I really educated her that, I showed her that the medication, her son came with her this time, who actually was in the US military. So her son was in the process of trying to apply for a TRICARE for his mother. And I educated her a lot on the importance of sticking to medications. And I showed her that it wasn't very expensive. It was on one of these care plans. And we were able to continue that medication because she said she felt so much better. She said, I feel so good with this medication. I don't want to take it every day because I want to spread it out. So, it was nice to know that, in listening to our patients, we can find the diagnoses and be able to provide proper care and proper treatments so that they do, end up feeling better. So these are some of our references, and I think that's all we had. Any questions?
We thank you guys for taking the time to listen, and please feel free to reach out to us. We are always looking for volunteers in our refugee clinic. I have to give a plug for the refugee clinic. You don't have to come every single month. You don't have to come every single time. We'll take what we can get, and we just ask that you consider it and reach out to one of us if you're interested in volunteering. We need as many providers as we can possibly recruit. So not just in adult medicine, but even in pediatrics, med peds, etc. Thank you, guys.
What an outstanding presentation. I think the writer Gertrude Stein said that for something to make a difference, it has to make a difference. And what you all are doing really does make a difference. And it's in a couple different dimensions. You inspire us, you help patients, you bring luster to the university, but you also bring luster to America as a country. And we all stand in gratitude for all that you do.
Thank you, guys. Have a good
Thank
afternoon.
you.
Are there any questions?
I think that was a very, very complete, informative talk. Those of you in the audience need to encourage your colleagues that haven't seen it to go to the site and watch it. I know I've been doing international work for years, and I learned a tremendous amount. Thank you.
All right, thanks everybody.